In the next session, first of all, you have to look at the rhythmicity. By looking at this tracing, you can see it mostly is rhythmic, except here in V4, V5, and V6. Let's look at first the heart rate. The heart rate, because it's rhythmic, you can calculate by looking at the big square between the RR interval. Here we do have 1, 2, 3, 3.5. So this means the heart rate is between 75 and 100. So we can make it around 80. Another possibility, if you want, you can count the R's in a certain interval. This is 1 second, 2 second, 3 second, 4 second. If we count for 4 seconds, we have to multiply by 15 how many R we are counting in 4 seconds. 1, 2, 3, 4, 5, 6. 6 times 15 means 90. Next, we have to look at the P wave. Do we see P wave? Yes, we do. In lead number 2 and in AVR. In lead number 2 is positive, in AVR is negative. So that originated from the sinus. The shape of the P looks identical to each other, so that can confirm there's a sinus impulse formation. The morphology of the P wave. The morphology that you should fit the P wave in one square or 1/4 of this big box. That's okay, that's fine. This P is fine. It doesn't have any kind of hypertrophy. Next, the PR interval. We are going to evaluate whether every P followed by the QRS and every QRS is preceded with a P wave. Yes, it does. And the interval, the PR interval, is constant and normal. Next, the QRS, the width of the QRS. The width, it should not exceed the 0.12 seconds, so that's fine. This means narrow QRS. Now, first, we have to look at lead number 1 and AVF because they are both positive. For sure, the axis is normal. If you find a normal axis, the next one you should look 1, 2, and 3. Which is the biggest one? Lead number 2. And 1 and 3 are about the same, so that means the axis around 60 degrees. If you are looking at and checking the AVL about equiphasic, so it's meaning exactly perpendicular to AVL is lead number 2. So the axis is 60 degrees. Next, we have to look at in the QRS complex. Do we see any pathological Q wave in the QRS complex? By looking through the limb leads, I cannot see anything. In the chest leads, V1, V2, V3, V4, V5, no, we don't see any. And if you look at in V1, V2, V3, the R progression is normal, so there is no R regression or any other changes. Here we do see in V4, V5, V6 a early coming bit, and that's QRS is wider than the previous one and has a negative STT changes. So this coming from the ventricle. So this is a ventricle premature beat. A ventricle premature beat is compensated, meaning that this distance it should be equal with this distance. Let's count the squares. 1, 2, 3, 4, 5, 6, 7. Here 1, 2, 3, 4, 5, 6, 7. Yes, that's a compensated ventricular beat. The next one we should look at the ST segment. The ST segment can be elevated or depressed. Here we don't see any changes of the ST segment. Here, however, in V4, V5, V6, we do have a horizontal ST depression. That can be the sign of subendocardial lesion. Looking at the T waves, the T waves are positive, mostly positive. In AVR is negative. In AVL, a little bit biphasic or flattening, but in the chest leads, they looks nice, except in V4, V5, that's a biphasic one. So the final diagnosis, that's a sinusism with ventricular escape, ventricular premature beat, and a subacute anterior and lateral lesion. The next ECG again is rhythmic. You can see the rate is tachycardic, it's more than 100. The rate exactly, if you count, is 120. Again, we can count 1, 2, 3 seconds, but it's not exactly the same. So it's around 120. Looking at P wave? Yes, we do have P wave, so that's a sinus tachycardia. QRS is not wide. The axis, however, one positive, AVF negative. Lead number two is negative, meaning that's an extreme left deviation. AVR is positive, meaning that we do have a minus 60, minus 70 axis. Now, by looking at the QRS complex, the pathological conditions, first of all, we do see in the chest leads V1, V2, V3, V4, V5, V6, and R regression and the ST elevation all the way up to lead number 1 and AVL, because we do have this dome-shaped ST elevation that represents a extensive anterior myocardial MI. In the opposite, for example, 2, 3, and AVF, we do have the reciprocal changes because AVL is almost opposite to lead number 3. So in the lateral, high lateral lead can be causing a mirror image in the inferior leads. The next ECG, it's the heart rate, it's rhythmic. The heart rate is close to 100, about 96 or 95. We do have P wave, and this is sinus P wave. PR interval is normal. QR width of the QRS is normal. The axis 1 positive, AVF is negative. Lead number 2 is a little bit more negative, so I would go for the minus 40 degrees. Looking at the pathologic condition, you can see lead number 1, AVL, negative Q wave, and ST elevation. And very similarly in V1, V2, V3, V4, V5, V6, pathological Q wave with ST elevation. So that's again an acute, extensive, anterior MI. And again, the red arrow dotted the mirror image or reciprocal changes due to the high lateral MI. The next one, again, the heart rate is rhythmic. Now that's the rhythm is normal. Again, we do have P wave, positive lead number 2, negative AVR, so this is sinus one. The morphology P wave is normal, PR interval is normal, width of the QRS is normal. Axis 1, 2, 3. 2 is the smallest one, 3 is negative, 1 is positive, AVL is positive, so that is close to AVF is negative, so it's close to minus 30. By looking at the pathologic condition, lead number 1 AVL, we do have a negative Q wave, pathological Q wave, and V1, V2, V3, V4, and all the way to V6, we do have this pathological Q wave. However, the ST segment is not elevated, the T wave is inverted, so that can represent a subacute extensive anterior MI. The next one, again, is rhythmic. Heart rate is 90. We do have sinus P wave, positive, negative, positive in 2 and negative in AVR. Morphology and the PR is normal, QRS is not wide. Axis 1 positive, AVF is positive, it's almost 0, surround is 0, the axis is 0. Looking at the pathological conditions, we do have V1, V2, V3, V4, and V5, V6. First of all, in V1, V2, we do have the pathological Q wave and T inversion, and we do have the T inversion in V5, V6. And similarly, the ischemic changes can be seen in lead number 1 and AVL, so that can be a subacute anterior MI. In the high lateral and the lateral, we do have only the ischemic changes. Next, rhythmic. Heart rate is around 80. The impulse generated by the sinus node, P morphology is normal, PR is normal, width of the QRS is normal, 1 positive, AVF is a small one, so this is why it's close to 1 or close maybe around 20 or 10 degrees because AVF a little bit positive. Pathological condition, here we do have a premature ventricular beat, and additional one, we do have ST elevation in lead number 1 and in AVL, but nothing else. A little bit ascending ST depression can be seen in V4 and V5, and if you look at the QT interval a little bit shorter, so that can be the sign of a hypercalcemia, but in the limb leads we do not, well, in the limb leads as well, so I would go for the hypercalcemia as well. And of course the high lateral hyperacute MI. This dome-shaped ST elevation is very characteristic of a hyperacute MI. Again, this ECG is rhythmic one. The heart rate around 90. P is a sinus, PR is normal, QRS is narrow, axis around 60 degrees because AVL we do have the epiphasic leads. The pathological condition that you do see in lead number 2, 3, and AVF, we do have this T-on dome phenomenon, so it is ST elevation, and in the anterior leads we do have the ST depression that can be due to a posterior MI, a posterior hyperacute MI, because the R propagation is normal, so it doesn't have a right or the right shifted R wave, so the pronounced R wave, so that's a hyperacute infero-posterior myocardial MI. In the next again, we do have rhythmic heartbeats. The rate very similarly 90. P wave is sinus, PR is normal, axis 1 positive, 2 negative, extreme left deviation. AVR is negative, so this is between minus 30 and minus 60. Looking at the pathologic condition, first of all, we do see a premature ventricular beat coming into almost in the middle of here. And we do have pathologic Q wave in lead number 2, lead number 3, and AVF, and a negative T wave. That can be a sign of an old inferior MI.